Today I will be joined by Dr. Karnik Shah. Hey Karnik,
Hey Dr. Vishal, how's your day so far?
it's going great. Okay, so today's topic is importance of socket preservation for the future implant placement. So the key points that I will be discussing today will be atraumatic extraction, bone grafting options, barrier membranes, immediate bone graft with non-resorbable membrane, immediate bone graft with resorbable membrane, and delayed bone grafting. Let's take a look one by one. So atraumatic extraction. So the steps that I take it in will be as such. So this is number 32. This is the periapical radiograph of number 30. Decided to extract. So the first step of the atraumatic extraction is with the long taper diamond burr. I section the tooth from the furcation area and I start to extract the tooth, the pieces of the tooth one by one. Once that's done, I will take the periapical radiograph just to confirm it. Then I will irrigate with the saline. Then the next question will arrive as which type of bone graft shall we use? There are different options of the bone graft in the market, which will be as such. Xenograft, which will be bone taken from the animal source. We have allograft bone graft, which is a graft from the donor of the same species. Alloplast bone graft, which is synthetically made, and autograft is something bone from the patient's own body. So allograft are of two types, FDBA and DFDBA. FDBA has a resorption rate which is lower than DFDBA. DFDBA has more morphogenic protein and both of them are osteoconductive. So this is how I graft the sockets. In this situation, I did not use barrier membrane because all of the socket walls were present. In those situations, one does not need to use barrier membrane. So I just put the collar plug or collagen plug on top of the occlusal surface. So now let's discuss the barrier membranes and when to use, why the necessity of the barrier membranes. Barrier membranes, we have non-resorbable membranes and resorbable membranes. Non-resorbable membrane is a type of cytoplasm membrane. It could be titanium reinforced and non-titanium reinforced. Resorbable membranes, we have collagen sponge, collagen membrane, etc. The example of non-resorbable membrane, as I mentioned, the cytoplast, which will be textured, non-textured, titanium reinforced. Resorbable membranes will be Orograft, Oloderm, BioGuide, etc. Let's see the clinical cases that I had treated. In the first case that I will be discussing is immediate bone graft with non-resorbable membrane. So this is the tooth number 12 area. From the picture, you can see that the tooth has a buccal plate missing. So I ended up extracting that tooth, cleaned the socket properly, and then grafted the socket with particulate bone graft. Where I will not be able to get the primary closure, I use non-resorbable membrane. Non-resorbable membrane, you can left it exposed in the oral cavity. So this is the 1 week follow-up appointment. As you can see from the picture, there is not much of a food accumulation around the sutures or the membrane. Let's say the second case, immediate bone graft with resorbable membrane. We're discussing about number 18 area. Patient was in severe pain. So after the clinical examination and radiographical examination, I came to the conclusion that patient had a vertical fracture on number 18. I started to section the tooth. Then after sectioning the tooth, I ended up extracting the tooth. As you can see from the picture, there's a vertical fracture line that goes all the way from apex to the coronal portion of the tooth. After that, I cleaned the socket and started grafting the tooth with particulate bone graft. And in this particular situation where I was able to get the primary closure, I used resorbable membrane. Delayed bone grafting in situations where there's a bone loss along with there's a soft tissue or dehiscence or soft tissue loss. In those situations, what I tend to do is I will extract the tooth, clean the socket, and I generally wait 5 to 6 weeks for the soft tissue to regrow, and then after 5 to 6 weeks I will open up the site and then graft so that I can manipulate the soft tissue easily. So let's see a clinical case. This is my patient. I'll be discussing about number 3 area. As you can see on the left picture, there's a soft tissue dehiscence or the soft tissue loss along with bone loss on the palatal side. Ended up extracting the tooth, clean the area thoroughly, and deepithelize the palatal flap. Pack the collagen plugs into the socket and sutured in this fashion so that the soft tissue will have approximation as you can see in the picture. The reason is The palate is all keratinized. In 5 to 6 weeks, you will see that the palate will be re-keratinized and the soft tissue will regrow. So to conclude my presentation, the key take-home message is atraumatic extraction, selection of the grafting material for socket preservation, and use and type of barrier membranes. I hope you learned something from today's lecture. So these are the simple steps that one need to implement in the clinical practice for a better outcome or better result.
Thank you, Dr. Vishal. That was a really, really good presentation. I think you kind of showed us in a nutshell what clinical scenarios we come across in everyday practice and what are small, simpler steps to kind of manage it. And even if people who are not very comfortable with doing immediate extraction, immediate implant placement, it's a good idea for them to know what options they have so that they can plan for implants in the future. So my first question is, in one of the first cases, you showed us that you use a collagen sponge on top of the bone graft, but I did not see any sutures. How do you ensure that the collagen sponge does not come off?
Okay, so to answer your question, in that particular case, I used periacryl. Periacryl is like a glue. If I don't have a periacryl, then I try and put the sutures.
So the second question I have is that when you showed us the case for non-resorbable membrane that was exposed in the oral cavity, how do you ensure that it does not accumulate food? Basically, what instructions you give the patient?
So to answer your question, the sutures material like silk, vicryl, cytoplast sutures. Silk is the suture that will accumulate a lot of food particles, and the second will be vicryl and then cytoplast. I try and tend to use cytoplast sutures. Cytoplast sutures will not accumulate as much food particle as opposed to silk suture. And after a week, I ask them to start using saltwater gargles.
Okay, that's very important. I think that's good to know, and all our viewers appreciate that. You know how it is important that not just the membrane but suture material is also very, very important. And then the last question I have is that if a resorbable membrane ends up staying exposed in the oral cavity, are there any specific precautions that you do, or what is your protocol for that?
Okay, a non-resorbable membrane, as I said, if it is left exposed in the oral cavity, that's okay. The resorbable membrane case that I showed, there was a little bit exposure around. I tried to get the primary closure, but as you know, in the extraction sockets, it's very difficult to get the primary closure. In case of resorbable membrane, I keep the patient on a follow-up appointment 1 week later, 2 weeks later, 4 weeks later. If I see any infection during the post-operative appointments, then I take the membrane out. If not, then I will leave it alone, the membrane, to resolve itself.
Thank you very much, Dr. Vishal, for that lovely presentation and answering my questions. I think all our viewers will appreciate that how we are sharing small clinical tips and tricks with them. And to all the viewers, thank you all for tuning in. And if you like our video, please give us a like, please show us some love, and please subscribe so that we can keep updating more and more future videos and keep sharing our clinical cases with you. Thank you so much, guys.
Thank you.